Okay, so welcome to this new session of our course. Today we are continue our journey with the retina. So we will go to try to cover today the macular diseases and fundus dystrophy. So I hope that you are ready for today's journey. Let's start with the macular disease. So if we talk about macular diseases, well, the first thing that we should discuss will be the age-related macular degeneration. So why? Because it's very common. The age-related macular degeneration it is a disease that affects the elderly population, and it is responsible for loss of vision, the irreversible visual loss in industrialized countries or in the Western countries for patients who are above 50 years of old. And if the patient is getting older and older, like if more than 70 or 75 years old, the risk is even more and more. So this disease shouldn't be overlooked. This disease is very, very important. So for those of you who are working in the West or they are going to work in the West, you will see how prevalent is this disease. You will see like most of your patients, your like in general ophthalmology clinic of the elderly population will have this disease of age-related macular degeneration. Okay, so that's why it is very important to understand everything about it. For those who have age-related macular degeneration, we will say that it will be classified into two types. One is called the dry type, and the other will be called the wet type. The 90% of those patients will have the dry type, and 10% will have the wet type. So why are some people are at risk to develop age-related macular degeneration? First of all, as the name implies, it is called age-related. So the risk increases with age. So the more the age, the more the risk. As I told you, it will be more common or it is the commonest cause of visual loss above 50 years old in Western countries. If the patient is above 75 years old, then the risk becomes 3 times or threefolds. So this is one thing, one risk. The other is the race. It was found that this disease is more common at the white population, so it is understandable. It's more common in the Western countries. Also, it has been found that it is more common in females. Maybe it has a relation to fat, as I'm telling you right now. Smoking here is very, very important risk factor. It was found that smoking double the risk. So this is one thing that we can control. As you can see, the all other risk factors, it is uncontrollable. However, the smoking it can be controlled. So the best advice or the if we want to give a single most important advice to those patients is to stop smoking. Also, the diet has been linked to the increased risk of age-related macular degeneration, as it was found to increase with obesity, especially the kind of drusen which is called the intermediate sized drusen or soft drusen. And it also decreases with the antioxidants, which are used for prophylaxis from development of advanced diseases. I'm going to show you right now. Family history also, there are some genetical factors have been proposed for that was linked to age-related macular degeneration. So those who are have family history of age-related macular degeneration, they will have 3 times the risk if there is a first-degree family member is affected. Okay. So these are the factors that are affecting, or the factors that are causing increased risk of age-related macular degenerations. Other factors include like if there is cardiovascular disease, or if there is hypertension, or hypercholesterolemia. Also, those who are whitish or light color iris, these are also at risk factor for developing age-related macular degeneration. Okay, so let's try to understand what is meant by age-related macular degeneration. So what is the process of degeneration that happens to the macula, which occurs as an aging process? It can be classified into two types. First of all, it is the dry type, which is referred to as drusen. So drusen is coming from a German word, like it will meaning like potato. It will be like the shape of a potato. So it's called drusen. And the wet type is called choroidal neovascularization, or CNV. So how the drusen looks like, and this is how age-related or CNV looks like. So what is the pathology mainly? The pathology in the drusen is that there is a deposition, there is like extracellular deposits at the interface between the RPE and the Bruch's membrane. So there is yellowish deposits between the Bruch's membrane and the retinal pigment epithelium. These deposits can consist of wide range of materials, like fat, for example, and it was found that it can be either immune mediated or it can be as a result of the waste products of the RPE metabolism. So the body, as an aging process, is not able to get rid of these waste products. So here again, you see this photo. This is the dry age-related macular degeneration. This is the lipofuscin pigment present within the RPE. Unfortunately, the RPE is not able to get rid of it, so it will be accumulated beneath the RPE, between the RPE and the Bruch's membrane, leading to this deposits present here in the retina, as you can see here as well. So this is the dry type. The wet type is called the choroidal neovascularization. And in this type, there is a certain genetical factor and angiogenic factor that will result in development of abnormal new vessels from the choriocapillaris. So here are the choriocapillaris. These are the angiogenic blood vessels, which appears due to certain factors, the same risk factors that we mentioned. And these new vessels are first to become below the RPE, then may cause break through the RPE and become subretinal, and may bleed, causing subretinal hemorrhage. So here are the choroidal vessels, the abnormal blood vessels, causing sub RPE hemorrhage or subretinal hemorrhage, or can break through even into intraretinal hemorrhage. So this is the choroidal neovascularization. That's why it's called the wet type, because it involves blood vessels that can ooze blood, can ooze lipids, causing subretinal exudation. So this is the pathology of the choroidal neovascularization. Okay, again, the pathogenesis of the dry age-related macular degeneration. There is sub-RPE deposits of this drusen material below the RPE, and there could be they can be small at start, then they become large, and those larger drusen and intermediate drusen will be increasing the risk of developing what's called advanced age-related macular degeneration, in which there is atrophy of the retinal layer. So this deposition, this will be can be complicated by what's called geographical atrophy. In geographical atrophy, there is loss of the outer retinal layers. Okay, this is the effect of these drusen, and this will result in irreversible visual loss. So this is the case of advanced diabetic disease in geographical atrophy. In advanced diabetic disease of wet age-related macular degeneration, that there will be sub RPE or there is choroidal neovascularization that with these blood vessels will cause sub RPE hemorrhage or subretinal hemorrhage and intraretinal hemorrhage. So this will result in a massive loss of vision, and this is also called advanced age-related macular degeneration. So to classify the age-related macular degeneration, we can classify according to the disease or according to the stage. So it can be classified into dry age-related macular degeneration, which starts by drusen, then can eventually develop into atrophic age-related macular degeneration as in geographical atrophy, or it can be wet age-related macular degeneration, which has a spectrum of 4 diseases like choroidal neovascularization, pigment epithelial detachment, polypoidal choroidal vasculopathy, and retinal angiomatous proliferation. Okay, so regarding the progression or the classification according to the progression. So first of all, let's start by the when there is no age-related macular degeneration. The striking or the surprise that I'm going to share to you right now, that not every case of drusen can be belong to age-related macular degeneration. So it was found that the drusen can be like a normal finding in some elderly population. So it is understandable that their RPE are maybe exhausted and there is sub RPE deposits of this drusen material. And but at this stage, or if it is very small, like less than 65 or 63 microns, and they are not very numerous, then this is still considered no age-related macular degeneration, as long as that there are small, they are few, there is no pigmentary changes in the retinal pigment epithelium, and if we did adaptation test, we will find that there is a normal adaptation test. So this is considered normal patient, normal individual. There is no age-related macular degeneration. So if the MCQ exam tells you that every patient with a drusen, he is an age-related macular degeneration patient, the answer is no. We want to prevent the age-related macular degeneration from occurring, but it is not mandatory for this patient to have age-related macular degeneration. So as I'm going to show you right now, it will be the risk will be increasing more with the increase the size. So it will be the age-related macular degeneration will be more or less linked to the size of the drusen. Okay, then the patient may pass into the subclinical age-related macular degeneration where there will be the same criteria like no age-related macular degeneration, but there is impaired dark adaptation. So this will be like the alarm that the patient is going through the AMD stages, or he is progressing to AMD. For the early AMD, there will be medium-sized drusen, like there will be more than 65, but they are less than the size of the hard large drusen, which is less than 125 micron. These numbers were asked before in the exams. But again, there is no age-related macular degeneration, pigmentary abnormalities with impaired adaptation. Intermediate drusen means that there is at least one large drusen, or there is one large drusen more than 125 micron. So it will be mostly they are of intermediate size between 65 to 125. Or it could be there is one large drusen. This is still considered an intermediate age-related macular degeneration with pigmentary abnormalities within the macula. For the advanced cases, advanced age-related macular degeneration in which there is visual loss, severe visual loss. This for the dry type, it will be the geographical atrophy. For the wet type, in which there is neovascularization or neovascular age-related macular degeneration. Okay. Okay, so these are the etiology, or the pathogenesis, the risk factors, the classifications. Let's now go into more details about each one of them and how it does present and how would we investigate it and how would we treat it. Starting by the drusen, the patients sometimes they can complain of gradual loss of the central vision, especially when there is pigmentary changes in the central macula, like you can see here, there are some RPE clumps. Or for many occasions, it is asymptomatic. The patient doesn't have any symptoms. So it will be just discovered accidentally. When you examine the fundus, you will find that there is widespread macular drusen. There will be RPE clumps. There will be like multiple small to medium to large subretinal deposits of variable size. They are confined within the macula. Also, if the patient has visual loss, and then you can see the patient with the geographical atrophy, where you see area of atrophy of retinal layers. So this is the end stage of drusen. Okay, so we can present with either the drusen or age-related or the geographical atrophy. So what are the types of the drusen? The drusen can be classified into 4 types: the hard, the soft, the basilar laminar or cuticular, and the calcific. So how does everyone looks like? In the hard drusen, like those hard drusen appears as multiple small yellowish spots. Usually they are less than 50 microns. They will be small. And this will be mainly the hard. So the hard, usually they are smaller in size. For the soft, it will be more larger in diameter. It will be like more of intermediate size, like between 63 and 125 micron. They will be less dense than the hard, so they will be less numerous, more fluffy, more blurred margin, or sorry, they will have like tapered edges, and those will be have more incidence of age-related macular degeneration. So they will have more incidence of developing advanced age-related macular degeneration. This is very important. The soft is the most risky, and it was also linked to a fatty diet. The basal laminar or the cuticular appears as diffuse, confluent, densely packed, yellowish white lesions, appears as a starry sky, like stars in the sky. So this is called the basal laminar or cuticular. And finally, there is the calcific, and the calcific here appears as sharply demarcated, glistening. You see the glistening? And usually it is associated with RPE or geographical atrophy. So hard, basal laminar or cuticular, soft calcific. To remember these four or the four names, remember the HSBC bank. H for hard, S for soft, B for basal laminar or cuticular, and C for calcific. Okay, so if we have a patient with dry age-related macular degeneration, like with drusen, and we want to confirm diagnosis, we can do the fluorescein angiography or the OCT scanning. In the fluorescein angiography, the appearance of these lesions will be variable, depending on what is the nature of the material deposited into this drusen, and also the state of the overlying retinal pigment epithelium. So for example, if there is overlying RPE atrophy, this will result in window defect. So it will result in early hyperfluorescence. Also, if there is a soft drusen like that, like this patient, this soft drusen, this lipid content may cause blockage of the fluorescence. So it will result in blocked fluorescence rather than hyperfluorescence. Also, it sometimes the materials can show late staining. So for the early frames, you can see the staining of the optic disc. Sometimes the drusen will show late staining, hyperfluorescence in the late stains. So the fluorescence will be showing the lesion, but there is no single rule for all lesions. The most important here is the OCT scan. For the OCT scan, it will show focal irregular elevation of retinal pigment epithelium. Again, there is focal irregular elevation of the retinal pigment epithelium. Why? Because of the sub-RPE deposits. These RPE deposits causing this irregularity in the retinal pigment epithelium. So what will be the consequences? Sometimes the patient will not present with drusen, but it can result in geographical atrophy. So you see the fundus, you will find an area of atrophy, macular atrophy. And for the fluorescein angiography, you will see hyperfluorescence due to window defect. So there is no RPE. That's why there is pronunciation of the fluorescence from the underlying choroid. And when you do the OCT scanning, you will find that there is thinning or atrophy of the RPE and the outer retinal layers. That's why there were the reflection from the choroidal blood vessels appears very pronounced. You can see here are the choroidal blood vessels appear very bright. Why? Because of the thinning of the retina. So that's why those patients will show this hyperreflectivity. So those patients will, with geographical atrophy, they will have loss of the outer retinal layers. So now we know how a patient with drusen, either in the early types or in the advanced age-related macular degeneration with geographical atrophy, will look like. So how would we manage this patient? First of all, we should always advise the patient to stop smoking. This will decrease the risk of developing advanced age-related macular degeneration. Also, we do what's called Amsler grid. Amsler grid is like a chart like that with vertical and horizontal parallel lines and a central dot so that when this patient fixate or looks at this center every night before he sleeps, so he should notice that the surrounding lines are regular. However, if at any point the patient notices there is irregularity of the surrounding lines, then this can denote the presence of a macular pathology. So Amsler grid is used to detect macular pathology. So he can notice distortion of the lines. He can notice the presence of a black spot in the center. So the black spot corresponds to a central scotoma. The distortion of the lines corresponds to the metamorphopsia. Also, if in doubt of drusen, we should do the fluorescein angiography and OCT scan. Also advise the patient to eat green. It was found to be helpful to minimize the development and the progression of age-related macular degeneration. Also avoid sun exposure. Also, this was linked to age-related macular degeneration, the ultraviolet rays specifically. Also to take vitamins like vitamin C and vitamin E. It was found that these vitamin supplements decrease the development of advanced age-related macular degeneration, and this was a result of a study called the ARIDS study. ARIDS, or Age-Related Eye Disease Study 1. This study was done to check for to decrease the incidence of development of advanced age-related macular degeneration. So those patients who were recruited for this study had daily regular intake of vitamin C of 500 milligram, vitamin E of 400 international unit, vitamin A in the form of beta carotene of 15 milligram, and zinc of 80 milligram. This is the zinc with copper. So the outcome of this study is to see whether this regimen will decrease the risk of development of advanced age-related macular degeneration. So the patients, those patients, or the recommendation of this study, that those patients who are above 55-year-old should undergo examination. If one or more of those criteria are present, then they should take the antioxidant. So the antioxidant is not given for everyone. I'm talking about the study. The study said or showed that if anyone with these 4 criteria, he will benefit hugely from the multivitamins formula. So if he has extensive intermediate drusen, or at least one large drusen, so this means that he has intermediate age-related macular degeneration. If he has geographical atrophy in one or both eyes, or if he has late age-related macular degeneration in the other eye. So the other eye maybe was lost from complications of age-related macular degeneration. In those patients, it was found that this regimen will decrease the risk of progression of age-related macular degeneration in around 25% of patients. And it will decrease the moderate visual loss in 90% of patients over 5 years. However, according to the study, this regimen is not beneficial in the early disease. So it doesn't prevent the progression in the early disease. Okay? So remember these 4 criteria, because it is very easy to bring these 4 criteria in an MCQ test. So this study was conducted. However, it was suddenly terminated. Why it was terminated? Usually when a study is suddenly terminated, this is because of a safety issue, that this study endangered the safety of the patient. Why this study endangered the safety of the patients? Because it was found that those patients had a risk of developing lung cancer. Those patients are smokers. Mostly they are smokers. And when they receive the beta carotene form of vitamin A, it was found that the beta carotene form of vitamin A in smokers increase the incidence of lung cancer. So this study was terminated for this reason. Another reason that it was found that the zinc, which is also included in the regimen of the AREDS1, has been associated with increased problems in the GIT, also the genitourinary. So there was a genitourinary and GIT side effects. So based on the results or the outcome of AREDS1, they were neglected and they conducted a new study called the AREDS2. So the AREDS2, they changed the regimen. So they make it like vitamin E and vitamin C will be the same, 400 international unit, vitamin C 500 milligram, but they use the lutein and the zeaxanthin instead of the beta carotene. So these are the forms of vitamin A that are used instead of beta carotene. They decrease the dose of the zinc instead of 80 milligrams. So the dose was now 25 to 80 milligram to decrease the GIT and urinary and genitourinary side effects. And the copper is 2 milligrams. So this is the formula which is used nowadays for the preparations that are given for age-related macular degeneration. So this is this, you can see these formulas all depends on the AREDS2 formula. This is for the age-related macular degeneration. Okay, let's now talk about the wet type, the choroidal neovascular membrane. What will be the complaint? So those patients are usually complaining. So it is unlikely that a patient with age-related of CNV will not be complaining. It can occur, but more commonly than the dry type, more commonly that those patients will be complaining. So those patients will have, let's read it again. It is a choroidal neovascular membrane. So there is the membrane that originates from the choroid, from the choroidal vessels present in the macula. So what will be the effect of this membrane? That it can cause diminution of vision. Why? Maybe the cause of the membrane itself, maybe because of that this membrane may cause hemorrhage, maybe it will cause subretinal fluid, like you can see here, the subretinal fluid. Also, it will be this intraretinal hemorrhage or other causes of hemorrhage or subretinal exudation. These are causing loss of vision. Also, the presence of fluid within the macula will result in metamorphopsia, which is the distorted vision. So this will be mainly the complaint of patient, either gradual loss of vision, metamorphopsia, or a central scotoma. Then by examination, you might find the presence of a grayish-green subretinal discoloration, also the consequences of this membrane like hemorrhage, like fluid, like lipid. So what will be the investigations? How would we investigate? Nowadays, the fluorescein angiography rule is becoming minimal. However, it is sometimes asked in the exam. So it was replaced largely by the OCT angiography. But the OCT angiography in the CNV is not asked. So we will be more focused on what's asked in the exams. What will be the types of the fluorescein angiography depending on the fluorescein angiography? So the types of choroidal neovascularization or choroidal new vessels or CNV, depending on the fluorescein angiography, is either a classic choroidal neovascular membrane or an occult choroidal neovascular membrane. In the classic type of the choroidal neovascular membrane, you can see that there is a presence of a lesion in this membrane with well-defined edges that has what's called lacy pattern. This is the lacy pattern. This is like an architecture. And it will show hyperfluorescence in the early phase. So even you see here, there is still no venous filling, no arterial filling, and it will fill with the choroidal circulation. So it will show early filling during the choroidal flush. And this hyperfluorescence, so there will be early filling in lacy pattern, then there will be leakage into the subretinal space. So with the these abnormal blood vessels will leak. So this membrane will be surrounded by leakage, and then there will be late staining. So even when the fluorescein fade off from the circulation, the membrane has high affinity to the fluorescein, so it will still attract the fluorescein, causing late staining. This is one form. It's called the classic, or it can be occult CNV. And occult CNV can take one of the two forms, either fibrovascular PED or pigment epithelial detachment. So in those patients, they have pigment epithelial detachment. And the pigment epithelial detachment usually appears as an area of hyperfluorescence due to the area of underlying choroid and the area of hypofluorescence. So like there will be together or two areas of one of hyperfluorescence and other of hypofluorescence. And this usually appears as it is occult. So all the occult, you will not be able to find frank hyperfluorescence in the early phases. So in the fibrovascular membrane, you still at 1 to 2 minutes, you will find irregular elevation of the retinal pigment epithelium. And as the time passes, you will find leakage, late leakage. So this leakage can show you the margins of the RPE detachment. Okay, and also it will show this granular appearance, of the membrane, of the fibrovascular membrane. The other type of occult choroidal neovascularization. So Dr. Hager, like dental fabric. Yes, exactly, Dr. Hager. So it will be like clothes, yeah. It will be like dental fabric. So I think that females will know this better. So the other thing, about the late leakage of the undetermined source. So those patients will have choroidal neovascularization, and you cannot appreciate an area of hyperfluorescence at the early stage. So it will be like 35 seconds, and you can still find an hyperfluorescence because the leakage is usually deep. Usually the leakage is from the choroidal or at the level of RPE with this speckled appearance. So this is speckled appearance with pooling of the dye into the subretinal space overlying these speckles. So this is called late leakage of undetermined source. This is a type of an occult choroidal neovascularization. As I told you, the fluorescein angiography is these terms of classic and occult has been very, very old, or have been very old terms, but they are still present in the books. Sometimes they are asked in the exams, but in practice, they are not very common. Maybe Dr. Amin will tell you much better on this topic than me. Okay, so the more rewarding is the OCT and the OCT angiography. In the OCT, it can be used to classify the choroidal neovascularization into 3 types. The first type, where there is subretinal choroidal neovascularization. So this can be corresponding to the occult choroidal neovascularization. So if we want to say something about the level of classic choroidal neovascularization and the occult choroidal neovascularization, in the occult choroidal neovascularization, the level will be below the retinal pigment epithelium. That's why it is obscured by the RPE. So the RPE will mask this choroidal hyperfluorescence. But for the classic, it will be above, or it will be superficial to the retinal pigment epithelium. That's why the hyperfluorescence is more pronounced. Okay, so the occult CNV can be classified, or can be belong to the type 1, which will be present here as an irregularity, thickening, and fragmentation of retinal pigment epithelium below the retinal pigment epithelium, and it can be associated with this neurosensory detachment. So there are some neurosensory detachment caused by leakage from this neovascularization. Type 2 choroidal neovascularization, it will be present above the retinal pigment epithelium. So you can find the RPE is thickened and irregular above the choroidal neovascularization is present here above the level of the RPE, which is this hyperreflective layer. And also there is association with the neurosensory detachment of the retina. In type 3 choroidal neovascularization, it will be the specific entity called the retinal angiomatous proliferation. In retinal angiomatous proliferation, there will be intraretinal, the pathology will be intraretinal itself, not below or above the RPE, but it is intraretinal. So we classify the choroidal neovascularization depending on the level of the new vessels. Okay, so these are the how would we diagnose the choroidal neovascularization. So what will be the outcome? What will be the fate, the complications of choroidal neovascularization? Well, it can ooze blood, can cause hemorrhage, leading to hemorrhagic detachment, either of the sensory retina or the RPE. So it is coming from the choriocapillaris, can bleed under the RPE, causing RPE detachment, hemorrhagic RPE detachment. This bleeding or this new vessels may break through the RPE, causing bleeding under the retina, causing the neurosensory detachment, or causing fibrovascular PED, or can cause intraretinal hemorrhage, or even it can break through up to vitreous hemorrhage. So the choroidal neovascular membrane is one of the causes that will result in multiple levels of hemorrhage within the retina. Or it can, these blood vessels, it can ooze lipids. So it can ooze lipids resulting in massive subretinal exudation. Remember last time when we saw the pictures of Coats disease where they have massive subretinal exudation up to exudative retinal detachment? The same thing can happen also in the choroidal neovascular membrane, of course, with respect to the age. Here the patients are old, and the location, the location of the exudation here is central, unlike the Coats disease. So the massive detachment, the massive exudation can be complicated by exudative retinal detachment. Also, this CNV, if untreated, can result in scarring. So it will cause a DC-form scar or subretinal scar, and resulting in permanent visual loss. And you see when to do the fluorescein, or sorry, the OCT, you can notice the high irregularity of the retina. So the retina is thin, there is fragmentation and degeneration of different retinal layers. There is drill or disorganization of inner retinal layers, and also there is loss of foveal contour. So this is a case of macular scar secondary of choroidal neovascularization. So in order not to develop these complications, how should we treat? Well, as we mentioned, we are only treating the active lesions. So we don't treat scars. We don't treat scars. We treat active lesions. So how can we know that this lesion is active? By these signs. If there is decrease of vision, progressive loss of vision, should be progressive. And if there is fundus hemorrhage, or if there is subretinal fluid, or if there is a leakage in the fluorescein angiography, because these signs and symptoms and investigations denotes the presence of a disease activity. So we only treat a disease if it is active. So how will we treat this case? It will be treated by the anti-VEGF. Remember the anti-VEGF that we discussed the last time, the Lucentis, the Avastin, the Eylea. And what will be the success rate of this anti-VEGF? They are now considered the gold standard for management of choroidal neovascular membrane, because it was found that they are very successful. 95% of the patients will maintain the vision. It will cause stabilization. It will prevent deterioration. And in 40% of patients, it will improve the vision. So about 50% or almost half of the patients will benefit from the anti-VEGF injection. So this will be they are very useful in such cases, and they can be also given by the regimen of classic or PRN or treat and extend, like we mentioned the last time. But what was the treatment before the advent of anti-VEGF? Actually, before the advent of anti-VEGF, there was another method for management called a photodynamic therapy. So the photodynamic therapy is it was like introduced like 20 years ago. It was like a kind of destructive lesion or destructive laser to destroy these new vessels. So what was this? How did this patient, or what was the methods of administering this kind of management or kind of laser? First of all, the patient is receiving an intravenous dye. This intravenous dye called the verteporfin. This was asked before in the MCQs. And this dye is light activated, or it will be photosensitive. So basically, when we are injecting this dye, it will pass into the circulation and until it reaches the choroidal circulation, and it will reach the abnormal new vessels. So this dye is photosensitive, meaning that if we point laser or if we direct laser to the patient by a specific wavelength, this membrane and these abnormal blood vessels, which has this photosensitive dye, will absorb this laser, resulting in destruction of these membranes. So after injection of the verteporfin, there will be like application of light of a specific wavelength. Then this light will induce a certain photochemical reaction within the target area, like here, resulting in thrombosis of the blood vessels of choroidal neovascularization. So are we using it right now? No, because it has less success rate. It is still causing collateral damage, so we cannot like giving it if the patient has fovea or central involving choroidal neovascularization, and it also has some complications like back pain. So it can cause back pain. This also was asked before in the MCQs. Okay, so now if we are going to treat a patient, how should we treat? If a patient has choroidal neovascularization, the gold standard is anti-VEGF, whether it is central involving or not central, we give the anti-VEGF. So does this mean that the photodynamic therapy now doesn't have any rule? No, there is still a rule for photodynamic therapy in a disease within the spectrum of choroidal neovascularization called polypoidal choroidal vasculopathy. So photodynamic therapy is better than the anti-VEGF alone for polypoidal choroidal vasculopathy. However, if we give combination of photodynamic therapy together with anti-VEGF, they will be better from photodynamic therapy alone. Again, if you want to treat the polypoidal choroidal vasculopathy, what will be the first option? Photodynamic therapy and the anti-VEGF will have the most high success rate, followed by photodynamic therapy alone, followed by the anti-VEGF alone. Okay, is it clear? Okay, so I know that we took so long in the CNV or age-related macular degeneration, but this reflects its importance. Let's now move to the other macular diseases. Let's talk about a common disease in the exams called angioid streaks. Angioid streaks is a kind of degenerative disease. There is a degeneration in the choroid. This degeneration leading to that the choroid become thickened and calcific. And since it is becoming thickened and calcific, it will be easily broken or it is brittle. And this will result in cracks like dehiscence present in the thickened calcified broth membrane, together with atrophy of the overlying RPE. So they appear as multiple radiating lines from the optic disc. These are irregular lines, they are narrow. This disease is present bilateral in both eyes. And the characteristic feature here is that they appears as in radiating fashion from the optic disc. This occurs due to weak or breaks in the weak broth membrane. Okay, so this shouldn't be confused with this pattern. What is this pattern? This is also a crack. Here is a crack, also present in the choroid, but the shape is very different. This patient has cracks radiating from the optic disc, but this patient has a crack which is concentric with the optic disc. So what is this? This is a choroidal rupture. So choroidal rupture has a crack in the choroid that is concentric with the optic disc. So why a patient with angioid streaks will complain of loss of vision? Maybe because this disease is one of the diseases that can cause choroidal neovascularization. So this crack will cause, or this break and in the Brox membrane will be an inciting factor for development of choroidal neovascularization. Also, if one of these cracks can involve the macula or involving the fovea with the crack, it will result in loss of vision. So this will be very obvious clinically. However, if we want to imaging, we can see clearly in the fluorescein angiography the presence of hyperfluorescence corresponding to these cracks due to window defect, early hyperfluorescence due to defect in the Bruch's membrane, so the underlying hyperfluorescence of the choroid capillaris will be clear. Also, it will be very useful to show the presence of complications like choroidal neovascularization. You can see here this hyperfluorescent lesion with late staining. Also, the OCT scan can be useful in order to see the presence of choroidal neovascularization as a complication. So this is what should be treated in such case. So for many diseases like angioid streaks, like best vitelliform dystrophy, as we are going to see later on, these diseases usually don't have treatment, but the treatment is to manage the choroidal neovascularization if it develops. Also, one of the very important topics in the exams, which is the associations of angioid streaks. The associations, the angioid streaks doesn't have a certain preference for age or sex or race, but it has certain systemic associations. Those are the pseudoxanthoma elasticum, Ehlers-Danlos syndrome, Paget's disease of bone, sickle cell disease, and finally the idiopathic. It can be just idiopathic. So this can be summarized in the word PEPSI. So PEPSI refers here to the names of the diseases that can be associated with the angioid streaks. Also, another important point in the management for those patients is that those patients have what's called a fragile eye. These eyes can be severely damaged by the minimal trauma. So they should wear polycarbonate glasses that should protect their eyes always by protective goggles to prevent some accidental trauma. Okay, so this is an easy one. The next one is central serous chorioretinopathy. Central serous chorioretinopathy is a disease that's characterized by hyperactive RP pump. So there is hyperactivity from leakage. There is leakage from choriocapillaris. This leakage will result in accumulation of fluid just below the neurosensor retina. And this leakage will pass through hyperpermeable sites at the retinal pigment epithelium, causing accumulation of fluid under the retina. So who are at risk of developing this condition? Usually, this disease affects the young middle-aged men. And if this disease affects the women, then the women will become older or should be older than men. Can anyone tell me another disease that we mentioned that mainly affect men, and if women are affected, they tend to be older? Can you remember? No, it is not PXF, it is the pigment dispersion syndrome. Remember when we said that pigment dispersion, exactly, Dr. Kinana, when we said about the pigment dispersion syndrome, that those patients tend to be young males, white athletes, and if it affects the female, they tend to be older. The same thing here. Young middle-aged men, affected women are older. It is usually occurs due to stress. So it is more commonly in type A personality. Type A personality are more prone to have the central serous chorioretinopathy, those who are perfectionists, those who are tend to be at high stress life. So maybe I'm telling you, and it is not a secret, that I diagnosed myself with the CSR. So like it was like 2 or 3 years ago when I felt like blurring of my vision, and it was like some period, or a stressful period at my life, and I'm a perfectionist by nature. So I suspected that I have a CSR. So I asked for OCT scan, and yes, I was found to have a CSR. it was resolved by its own. So just I'm telling you what will be the association. Okay, so young middle-aged men type A personality. And maybe also another interesting thing that there was a question in the exam that the question was asking about the CSR, and it's saying that a type A personality lecturer is presenting with central diminution of vision. So I thought that as if he was talking about me. Okay, so type A personality, hypertension, steroid use also have been linked to CSR, psychiatric medication use, and pregnancy. Also, there is a long list of risk factors about the CSR. Let me show it to you regarding systematic conditions and the medications. If you can't read them or memorize them, please do, because sometimes in the exam it's not only about type A personality and emotional stress, but in one exam they asked about the Helicobacter pylori. Helicobacter pylori. Okay, so Helicobacter pylori can be associated with increasing the CSR. Dr. Ala, why the steroids use causes CSR? Well, why the antihistaminics, why the antibiotics, why all these drugs? It will be, these diseases usually have unknown nature. So there is no obvious reason why each one of those will cause the disease. This is disease characterized by hyper leaky capillaries, choriocapillaris, and accumulation of the fluid through RPE through the neurosensor retina. So usually the cause is unknown for such cases. You're welcome. Okay, so what will be the problem? What will be the complaint of those patients? Those patients will have a symptomatic blurring of vision. So they will tend to have blurring vision, not loss of vision, but blurred vision. So remember that those patients have subretinal fluid. You can see the macular elevation by subretinal fluid. So the fluid will just cause blurring of vision, causing distortion or metamorphopsia. And the specific feature here is called micropsia. Micropsia meaning that the patient doesn't see the image distorted or like metamorphopsia, but appears small. So he will report that I will see everything small. Why this happens? Because of that, the fluid will cause wide separation of the photoreceptors. So we know that we perceive the size of the image and the shape of the image and everything about the image by the photoreceptors. If the photoreceptors are widely separated by the fluid, this will result in that the image will fall on a smaller number of photoreceptors, which will result in smaller size of the image. Also, they could have an area of visual darkening or a positive scotoma. The signs that you can see that there is a subretinal fluid like that. So you can see that you can appreciate the elevation of the blood vessels, which denotes that there is an elevation of the retina at this side. Also, one important sign here is the hypermetropic shift. So when you do refraction for those patients, you will find that they are maybe increasing or have hypermetropic shift about plus 0.5 or plus 0.75 diopters. Why? Because of the induced shortening of the axial length caused by the elevation of the retina at the area of central serous chorioretinopathy. This appearance of retinal elevation by subretinal fluid can occur in also other diseases that should be also put in your mind when considering a patient with a CSR. So we don't diagnose a CSR unless the others are not present. It is a diagnosis of exclusion. What are the other diseases? First of all, the optic disc pit. So in the optic disc pit, there is a defect in the optic disc tissue that will result in communication between the optic disc and the subarachnoid fluid around the optic nerve and the subretinal space, leading to escaping of the fluid to the subretinal space, leading to macular detachment. So we should always look to the temporal part of the optic disc for association with optic disc pit. Also, choroidal tumors such as choroidal melanoma can cause detachment, macular detachment. Choroidal neovascularization can ooze also fluid, causing detachment or causing a subretinal fluid, and Harada disease. Harada disease, the Wokto-Kanagi Harada or Harada disease can cause exudative retinal detachment. So exclude these 4 diseases before considering a central serous chorioretinopathy. The imaging will be diagnostic, or you can see the presence of elevation of the neurosensor retina. It is detached from the retinal pigment epithelium. And it could be also associated with a small area of pigment epithelial detachment. The fluorescein angiography will show a characteristic pattern. It will be called either smokestack appearance or an ink blot appearance. In a smokestack appearance, the patients will have early hyperfluorescent spot, and then with the later frames, the dye will pass into the subretinal space in a vertical manner, as if like there is smoke and stack. So it will be like a smokestack appearance. It will be in the early frames, and then with later frames, it will be like spread until the whole area of the subretinal fluid will be covered. So there will be like pooling of the dye into a certain anatomical space. The other pattern is called the ink blot, which is less common than the smokestack. This also asked before in the MCQs. There will be early hyperfluorescent pattern or early hyperfluorescent spot like here. However, the difference between the ink blot and the smokestack, that the enlargement of the ink blot will be concentric. There will be an increase in the size of the blot in all directions by the same manner, not a vertical ascend or not a vertical spread as in smokestack. Okay. So this is another pattern of hyperfluorescence which occurs in central serous chorioretinopathy. Okay, so after diagnosis, how would we treat? There are varieties of treatment. For many occasions, we tend to observe the patients. Sometimes many of those patients will show spontaneous improvement. Or we can start doing treatment. Like, what are the modalities of treatment? Like micropulse diode laser, like photodynamic therapy, like anti-VEGF, like oral diuretics, like such as spironolactone. It was also shown to be very helpful and very useful. So the question here, who to treat? Then we will now answer who to treat, then how to treat in the next slide. Who to treat? What are the indications of the treatment? If the patient is, you just observed him, but he didn't improve. So there was persistent fluid for several months without resolution. Or if there is recurrence with residual visual loss after previous episodes. So the patient had a recurrence and he had previous visual loss in the previous episode. Involvement of the fellow eye if the previous eye has permanent visual loss. So this is like, it is a rule for most of retinal diseases. Like one of the indications of interference that there was a poor visual outcome in the other eye. Indications for interference for severe NPDR to do laser is that the other eye had a severe outcome from diabetic retinopathy. Indications for giving vitamin supplements in age-related macular degeneration is that the other eye has poor outcome from advanced disease macular degeneration. Indications for management of CSR is that the other eye has a previous permanent loss from a previous attack. Indications like for doing laser in lattice degeneration, that the other eye like had lattice with complicated retina, or to manage a break or to do laser to a break, is that the other eye had a previous retinal detachment from a previous break, and so on. So for the retina, always think of the other eye. It will guide you for management of the same eye. Also, the occupational need of the patient. Like, for example, if the patient cannot tolerate to be blurred for just a few weeks or so, like if a patient works like as a pilot, or a patient is as a surgeon, and those patients need to restore their vision as soon as possible. So in this case, we treat. So how can we treat? Like I borrowed this flow chart from my friend Dr. Amin, the lecturer for the retina course. So we will see how, based on the guidelines, based on the retina guidelines, how would we manage a patient with a CSR? So if the CSR is not central, then we observe the patient. If after observation there is no resolution, or if it resolved and recurred again, then we do laser photocoagulation. Okay. If there is no if no improvement, or it is no response to the laser, or it is recurrent, then we do half dose photodynamic therapy or subthreshold micropulse diode laser. Okay. If the patient has acute CSR for 3 months and less, then observe and adjust the systemic, or it is central. So there is acute central serous chorioretinopathy for 3 months or less. Then observe and correct the systemic risk factors, like if he is on steroid, just stop steroid. If it improve, it will be good. If not improve, then he is now deemed as chronic CSR if it is more than 3 months. So if the patient has high visual demands, or the other eye suffered from poor visual outcome from the post-central serous chorioretinopathy, then again the patient should receive half the dose of photodynamic therapy. So there will not be like full threshold photodynamic therapy, but will be just half of the dose of laser, or they can receive a micropulse diode laser. If it is still recurrent, then we repeat the half dose photodynamic therapy or micropulse diode laser. If it is still recurrent or not resolved, then we give anticorticosteroid treatment such as iprilinone or the spironolactone. These are like mild diuretics and shown to be very effective for patients with CSR. And this is what I received. So those patients can even receive this from the start without laser, but it is usually reserved for cases which are not responsive to the laser, or where the patient refuses the intervention. If the CSR is complicated with choroidal neovascularization, then the treatment will be the anti-VEGF. Okay. Okay. So this will be one disease. The other disease is also very important, called the macular hole. Macular hole is a full thickness or a defect in the center of the macula. So what will be the complaint? Those patients can be present or can be idiopathic, or can be secondary to trauma, or due to some vitreomacular interface abnormalities, like there is vitreomacular traction or epiretinal membrane. And when this happens, when the macular hole happens, the patient will complain of diminution of vision, metamorphopsia, or a central scotoma. How would we test this condition? There is a clinical test called the Watzke-Allen test. Remember the name. Watzke-Allen test is a test for the center of the fovea, or the center of the macula. How would we do it? We take a thin slit beam of the light of a slit lamp and make it as thin as possible, and focusing it directly on the beam, on the fovea, and ask the patient if he can see the light as continuous light, or if there is any defect in the center. If he reports that there is a defect in the center, then it is called a positive Watzke-Allen test. Another test is, like any macular disease, it can be diagnosed by the Amsler grid chart, Amsler grid. And the differential diagnosis for this condition will be the macular pucker or the epiretinal membrane, solar retinopathy, and other differential diagnosis of cherry red spot, as we mentioned the last lecture. The treatment for the macular hole will be for stage 2 and stage 3, I'm going to show you right now, will be what's called pharmacological vitriolysis by a drug called the ocriplasmine or Gitria. This is a drug which will cause vitriolysis, so it will break the adhesions between the macula and the vitreous, which sometimes will be the responsible for the presence of macular hole. However, this drug is very expensive and it is not useful for every case, so it is mainly reserved for the stage 2 and stage 3. Or the gold standard with a high success rate is the parsoplantar vitrectomy with ILM peeling or internal limiting membrane peeling and gas tamponade. Okay. Okay, so what will be if we are in doubt of the macular hole, or we want to confirm the diagnosis? What should we do? The imaging, the fluorescein angiography will not be very helpful. It can show a window defect, hyperfluorescence due to window defect. But so what? We didn't gain any diagnostic value or prognostic value. However, the most important for the macular hole is the OCT. The OCT is used for staging. We know the stage of macular hole, or and for prognosis, whether this patient will gain good visual outcome or not, based on many factors like the shape of the hole. So this patient, you can see the patient here has a full thickness macular hole. There are cystic changes present at the edges of the macula, present at the edges of the fovea, the edges of the retina. Also, there is a complete posterior vitreous detachment with an operculum, an overlying operculum like that. Okay, Dr. Hager asked about the differential diagnosis. The differential diagnosis of macular hole is like first of all, it can be macular pucker, like what happens in the epiretinal membrane. I'm going to show you right now. Also, the solar retinopathy, the exposure of the sun to the infrared light, this will result in macular burn or foveal burn, resulting in the same picture of the macular hole. Also, all differential diagnosis of shiered spot, like central retinal artery occlusion. Remember from the last time, central retinal artery occlusion, we said that the macular hole is a differential diagnosis. Also, the presence of chloroquine toxicity, the congenital diseases or hereditary disease like Tay-Sachs disease or Niemann-Pick's disease or gangliosidosis. All these can be considered differential diagnosis for macular hole. Okay, so this is how would a macular hole present in the fluorescein angiography and the OCT scanning. So let's now dive more deeper into the OCT and learn more about its staging and its value in macular hole. So if we consider that this is the normal fovea, this is the normal architecture of the fovea, and this is the normal OCT showing normal regular layer of the all retinal layers. The macular hole starts by stage 1, and stage 1 is classified into stage 1A or impending macular hole and stage 1B or occult hole. In stage 1A, there is just vitreous contraction with foveal depression. There will be just a little bit of vitreous contraction and foveal detachment. So with foveal detachment, so you can see it's present with macular cyst. In the OCT, there is a macular cyst. This is what we can see. There is a foveal depression or decreased foveal depression with presence of macular cyst. For stage 1, but it's still here, you can see the photoreceptors are still an intact layer. In stage 1B, there will be a little bit of retraction of the photoreceptors. There will be dehiscence of photoreceptors. So here will be the IS-OS junction. The photoreceptor layer here will be retracted. So this will be present with the stage 1B or occult. There is a dehiscence of the photoreceptors. This is what stage 1B. In stage 2, there will be separation of the vitreous cortex from the retinal surface to form what's called a pseudo-operculum. So this is called a pseudo-operculum. There is a separation of the cortex of the vitreous from retinal surface, okay? And OCT will show like a partial thickness macular hole. There is a partial thickness opening within the macular hole. In stage 3 and stage 4, there will be full thickness macular hole. There will be separation of the pseudoperculum from the edges of the hole, and there will be a complete full thickness macular hole. So what will be the difference between stage 3 and stage 4? In stage 3, there will be full thickness macular hole, but there will be still posterior, there will be the posterior vitreous will still be attached. The posterior vitreous will still be, you can see here, the posterior vitreous is still attached to the retina. So there is no complete BVD. However, in stage 4, there is complete BVD. You can see the operculum here is floating within the vitreous. So there is complete vitreous separation. That's why in stage 4, the ocriplasmine will not be beneficial, because ocriplasmine is just will do the vitreal will do vitreolysis, so it will cause a vitreous separation, and here the vitreous is already separated. So stage 4 is like stage 3 plus PVD. Okay, so to summarize, here is a stage 1, stage 1A, there is a macular cyst with decreased foveal depression. Here is the stage 2, or sorry, stage 1B. And here is the stage 2, showing the partial thickness macular hole. Stage 3 with full thickness macular hole, and stage 4 will be full thickness macular hole with PVD. So this is the description of each one of these stages, starting from 0 to stage 1, 2, and 3, and 4. Okay, so as I told you, the management will be depending on the stages and depending on the visual acuity, and the prognosis will depend on chronicity. This is the most important, how much did the patient had this macular hole, and also what will be the changes in the hole. So like there is if there is any cystic changes within the hole, what will be the base of the hole? Is it wide? What will be the configuration of the hole? Is it like X-shaped or W-shaped, or there are different configurations? So these all will be effective in terms of the outcome. So actually, the surgery will cause success, anatomical success in many of these cases, like more than 90%. However, the gain of visual acuity is what is dependent on the factors that I'm telling you, the stage and the configuration and the chronicity of the case. Okay, so the next one is called the epiretinal membrane. Epiretinal membrane is when there is we see this patients can, or the etiology that those patients can be idiopathic. They develop epiretinal membrane like that, or it can occur secondary to some intervention like retinal detachment surgery, like retinal cryo, or pan-retinal photocoagulation or trauma. The clinical features will depend mainly on the extent and the severity. So for early cases, they are termed like cellophane maculopathy. There will be mild or minimal distortion of the macula. But for advanced cases, they are called the macular pucker. There will be fibrosis. There will be, you can see the presence of membrane here. And sometimes you can't appreciate the presence of membrane, but you can see its effect. It will cause a straightening of the blood vessels. This is straightening of the blood vessels. Okay, so if in doubt, the most valuable investigation will be the OCT. No rule for the fluorescein angiography here. So the OCT will be showing the presence of epiretinal membrane like that. And this epiretinal membrane, it will be causing what's called tangential traction. Tangential traction, like it will cause like corrugation of the epiretinal surface. This shouldn't be confused with the anteroposterior traction, where there is a vitreomacular traction, and the vitreomacular traction will cause anteroposterior traction over the retina. Okay. So this is called the epiretinal membrane. So how would we treat the epiretinal membrane? it depends again on the presentation. For minimal cases like those who have cellophane maculopathy, then no need, usually no treatment is needed. So usually they have visual acuity of more than 612. But for advanced cases where there's corrugation of the macula, then those patients need to do treatment. So this will be by parsoplanal vitrectomy and removing the adhesions. Dr. Islam, the pathogenesis of apiretinal membrane. Well, it was thought that it will come from retinal glial cells. The retinal glial cells and the retinal pigment epithelial cells will show abnormal proliferation. So there are fibrous astrocytes, there are myofibrocytes, there are macrophages. These will proliferate abnormally, resulting in formation of an apiretinal membrane. And also the inflammatory mediators will play a role, a very important role in such cases. So these inflammatory mediators will help in this fibrocellular growth. So there will be growth of the fibrous elements and cellular elements, and this will be triggered by inflammations. As what happens, for example, after the PRP or after cryo. Okay, again, I borrowed this flow chart from Dr. Amin about the management of the apiretinal membrane or the vitreomacular traction. So the broader term is called the vitreomacular traction. So it will depend mainly on the complaint. So the management here in the apiretinal membrane depends on the complaint. So if the vision is better than 20/60, then just observe. Observe for spontaneous release of the vitreomacular traction. While the apiretinal membrane tend to be stable, especially if the patient presented with good visual acuity without metamorphopsia or diplopia. And the patient is self-instructed to use the AMSAR grid and periodic examination. And in case of any presence of worsening of symptoms, then we do OCT. Otherwise, we should just follow up. So if a patient has good visual acuity, better than 20/60, just follow up for spontaneous improvement or spontaneous release of this traction. But what happens if a patient has poor visual acuity, or he has metamorphopsia or diplopia? Then we check if there is apiretinal membrane. So the apiretinal membrane here is the cause of this distortion. Then we do parsoplanal vitrectomy with internal limiting membrane peeling. If there is no apiretinal membrane, then vitreomacular traction, then the management will depend on the size of the traction. If the vitreomacular traction is less than 1,500 micron, so we do what's called pneumatic vitreolysis. Pneumatic vitreolysis. So we inject some materials that will cause lysis of the vitreous or breaking down of the vitreous, so that we will break this adhesion between the retina and the vitreous. If the vitreomacular traction with adhesion more than 1,500 micron, then the treatment is by parsoplanal vitrectomy with ILM peeling, especially if there is macular detachment. Okay, easy. So this is the management of vitreomacular traction depending on the visual acuity and the size of the vitreoretinal adhesion and other complaints. So this, by the way, this pneumatic vitreolysis or this by several gases. So there is like a C3F8, it has a success rate of about 80%, and SF6 or sulfur hexafluoride, it has a success rate of about 70%. And the pharmacological, like by Jetria or by ochriplasmine, it will have the least success rate to break the adhesion between the vitreous and the retina. It will be success rate like between 50 to 60%. Okay. Okay, so